As you've also heard, coronary physiology continues to be underutilized, and there's probably a number of reasons. It can take extra time. There are issues with the wire handling characteristics, pressure drift, and other factors associated with the measurement can be frustrating. If you're measuring FFR, the side effects of adenosine, it's expensive, and there is a small risk anytime you put a wire in a vessel. And as you can see, all of these issues are related to the need for a coronary pressure wire as well as the use of a hyperemic agent like adenosine. And so that raises the question, well, what if we could get all of this information just with the angiogram alone and no need of a pressure wire or adenosine? And that's where angiography-derived physiology comes into play. Now, 6 years ago, we published these data comparing FFR angio to wire-based FFR in a blinded fashion, 10 centers, over 300 patients. And you see that there is a very high sensitivity, specificity, and accuracy, all above 90% with FFR angio. And what we found even more impressive was if you look at the gray zone or around the cut point of the FFR cutoff of 0.80, this is where most tests have an accuracy of 50%, kind of like a coin flip. You see that FFR angio continued to have excellent diagnostic characteristics in that gray zone area. We also looked at how FFR angio compares with the non-hyperemic pressure ratios with regard to its correlation with wire-based FFR. And you see that the accuracy of FFR angio is actually higher than the resting indices when compared with pressure wire-based FFR. So what data do we have with FFR angio? Well, we have a real-world registry looking at the safety of deferring lesions in almost 900 patients and showing a very low event rate at 1 year in those patients where PCI was deferred based on FFR angio. So reassuring that you can safely defer if you get a negative FFR angio. And we also now have randomized clinical trial data from Japan, 400 patients in the Provision trial across 13 Japanese sites looking at intermediate lesions. The primary endpoint of this study was non-inferiority of revascularization rate of FFR angio compared with wire-based FFR. And the investigators met the primary endpoint. FFR angio was non-inferior and had a similar revascularization rate. They also saw a significantly lower radiation exposure, 20% reduction with FFR angio compared with wire-based. And they followed the patients now out to 1 year and have shown that major adverse cardiac events, both with and without procedural MI, were equivalent, and if not numerically lower, with the FFR angio group. So very reassuring data.